Aywa, 10-10 I'm supposed to finish. 58 years old woman admitted for elective cholecystectomy, non-eventual operative course. Post-operatively, she was on cefoxitin. Day 12, high-grade fever, watery diarrhea, severe headache. Confused, facial twitches, and tremor. حطيت كل الساينز والسيمتومز. يعني المفترض الدياجنوز يكون واضح الآن. And then she goes into multi-organ failure and ARDS. This is the X-ray. Pneumonias, actually it's bilateral, but more obviously much clear. No effusion. عشان ما يطلع واحد برا pneumonic. Yes. Send what? The one, whoever made the choice of tazobactam plus moxifloxacin plus vancomycin and tazobactam plus azithromycin, so I'm assuming 3 and 4. What was in your mind? Legionella. No, it's not. No, atypical is, it could be mycoplasma, it could be, but we are not talking about mycoplasma. We are specifically talking about one item of the atypicals, which is what? Which is Legionella. And the reason I'm bringing up this is hospital-acquired legionellosis. When you talk about atypical infections, you always think of things coming from community. Legionella is among the stuff that you really need to remember among sick patients admitted to the ICU, and hospital-acquired infection legionellosis is not uncommon. 18,000 cases of Legionella disease reported in US each year, 23 are hospital-acquired. Mortality rate is very high because, could be because of the disease severity itself, and because the other option is because the antibiotic choices are not adequate from day one. Most commonly linked to contaminated drinking water and rarely to oxygen humidifier, common in pregnant, immune compromised, and also common in alcoholic patients. The clues, or among the clues that we gave you, is the diarrhea, the severe headache, yes, the confusion, the facial twitches and tremor. Neurological manifestation is very common legionellosis, and the presence of urine, protein, and blood, plus the elevated white cell count, so the low white cell counts, the low sodium, 127. If I put the sodium 1118, the classical number in the exams, it will be very clear. So I have to put it somewhere in between. The high CPK. So this was a legionellosis. And your choices would have been tazobactam plus moxi plus vanco if you really want to be aggressive, because this patient is critically ill. If you choose tazobactam plus azithromycin, azithromycin is a very good drug for legionellosis if you use high dose, 500 milligram, and use it IV, do not use it oral. Tazobactam and tigecycline, by the way, is also another option. So tigecycline has a coverage for legionellosis and I can use. BAL respiratory samples are the best sample you get. BAL is better than bronchial washes. Cultures usually require special media, and they will take 3 to 7 days. Sputum cultures provide 80% sensitivities and 100% specificities. Culture for BAL specimen has sensitivity of 90% or more, so are the better. Direct fluorescence antibodies on the samples are quicker, and they will give you a quicker answer. Urinary antigens, if you do them early enough in the first 7 days, they can give you a better, or they can give you a quick answer. There are sensitivities around 70%, and you can improve on the sensitivity by doing centrifusions. People are trying to invest on PCR. Serology is not very useful. Third case. 65 years old diabetic on oral hypoglycemic, came to the ER with abdominal pain for 12 hours, clinically in pain, blood pressure 100/70, heart rate 100, saturation 93, room air, abdominal examination, mild tenderness, and no guarding and no rebound. CT scan, dilated bowel, thickened bowel. Diagnosis, ischemic bowel. What antibiotic would you give? He has, mild tenderness, no guarding, and no rebound. He has no evidence of peritonitis, but he has ischemic bowel. So they are asking you, surgeons are pushing you for antibiotics. You can ignore levofloxacin. We will not put levofloxacin as well. Cefepime plus flagyl, ceftriaxone plus flagyl, levofloxacin plus flagyl, ignore that. Imipenem, dorepinam, piperacillin, piperacillin, tazobactam. Ertapenem, tigecycline, imipenem. If we can نفصل التوأمين, the ID from tazobactam will be a great thing to do. Very difficult job. Very difficult job. Imipenem. Somebody votes for imipenem. So what choice?
Not take a side. The most important, not take a side.
Why?
He is sick. I don't like this side.
I agree with you. I agree with you.
What's sick? His blood pressure 170, heart rate 100, saturation 93. He did not go to ICU. Nobody talked about ICU here. But anyway, we'll not go over. As I said, this is not what I'm going to give you the reference of choices later on. So let's not stick to the antibiotic choice. We can answer this at the end, which choice you would make. Day 3 post-operatively, abdominal swab cultures by surgeon showed E. coli, but the patient was put on ceftriaxone and flagyl. Day 3 post-operatively, abdominal swab cultures by surgeon showed E. coli, Enterococcus faecalis, and Candida albicans. Patient on ceftriaxone and flagyl, as we said earlier. Patient temperatures on day 3 is 37.5, blood pressure is 127/70, heart rate of 70, drain showing a serosang fluid, and the wound looks okay. What would you do? Treatment should be continued as with no changes. Tazocine should be started to cover Enterococcus and flagyl, can be discontinued. Both Enterococcus and Candida should be covered. Tigecycline should be started, and antifungal only if patient becomes ill again. Add vancomycin to ceftriaxone and flagyl. He's on ceftriaxone and flagyl. We were a little bit milder in our approach. We were not very aggressive. Huh? Surgeon. Taban, first of all, you need to remember one thing. Surgical swabs are not anymore recommended. If you want to send anything from the surgery, you have to send fluid. And in the past, the surgeons were coming and just doing this on the peritoneum and sending it to you, and you get stuck with it. So that's number one statement. But this is what happens. And this is what they grow. And they are requesting you to make some comments. These are the findings, yes. Temperature 37.5, blood pressure. Don't do anything. Leave him alone. Type. Day 12 post-operatively, fever now is 39, blood pressure is 90/60, admission to ICU, and put in mechanical ventilation, norepinephrine started, abdomen tender, suspected anastomosis leak, drain is showing gram-negative rods, gram-positive in chains and yeast. Ertapenem plus vancomycin plus fluconazole, who would vote for that? Ertapenem plus vancomycin plus fluconazole, no? Time. Why would it not be on the best options? Yes, you are missing Pseudomonas. Type. Meropenem plus vancomycin. Tigecycline plus, not plus, sorry, 1 plus fluconazole, imipenem plus casbufungin, linazolid plus meropenem. I feel some people who are voting for linazolid. Type. Vancomycin plus tazocine plus casbufungin, linazolid plus piperacillin tazobactam. No change in the coverage, as this could be due to mechanical leak and not new infection. Arba. So imipenem plus casbufungin. Huh? Because Okay, all right. Let's settle this. As I said, this is never going to be settled. So the choice was imipenem and casbufungin. Now, there are two references, recent references, that everybody has to read, because they carry a very fundamental change in our approach on the choices of antibiotic for intra-abdominal infections, and more importantly, on the duration of antibiotic on the different intra-abdominal infection causes. The duration is shorter. It goes into the specific type of conditions and for how long you treat. These are the diagnosis and management of complicated intra-abdominal infections in adults and children, guideline by the Surgical Infectious Society and Infectious Disease Society, and the World Federation guidelines in the management of intra-abdominal infections. One is 2012 and one is 2013. It's a must-read pamphlets or literatures. Anti-enterococcal therapy, this is what they quote. Antimicrobial therapy for enterococci should be given when enterococci are recovered from patients with health care associated infection and not with a community acquired infection. Empiric anti-enterococcal therapy is recommended for patients with health care associated intra-abdominal infections, particularly those with postoperative infection, those who have previously received cephalosporin or other antimicrobial agents, selecting for Enterococcus species, immune-compromised patient, and those with valvular heart disease or prosthetic intravascular material. So you don't necessarily need to do anything on the first stage, but you definitely need to cover it on the second stage. Now, the coverage, if you are talking about fecalis, you can use ampicillin, piperacillin, tazobactam, and even imipenem. Those would still have a coverage against enterococci. If you are talking about faecium, or you have previously isolated other species, and there is a change in potential change in spectrum in your hospitals or stuff like that, then you can choose a little bit of a more aggressive care with the vancomycin or with linezolid. Initial empiric into anti-enterococcal therapy should be directed against an Enterococcus fecalis. Empiric therapy directed against vancomycin-resistant enterococci faecium is not recommended unless patient is very high risk for infection due to this organism, such as liver transplant recipient with an intra-abdominal infections or originating in the hepatobiliary tree, or patients known to be colonized with vancomycin-resistant faecium. Very important type of information. Empiric antifungal therapy for Candida species is recommended for patients with nosocomial infections also, and for critically ill patients with community-acquired infections. Now, the antifungal story. If patients are admitted to the ICU, mortality with Candida is extremely high in the intra-abdominal infections. And all the new recommendations nowadays in severely ill patients would throw some antifungal somewhere. And more importantly, almost all of them in sick patients will not mention azoles no more. No fluconazole in sick patients. Now, if you have an intermediate type of patients and you have a society or a community where the fluconazole azole resistance is not high, then yes. But generally speaking, sick, high Apache score, you throw echinocandins. Not gonna whichever. Huh? Empiric. This is all empiric. Yes, this is all empiric. And now, if you find the organism, you can de-escalate to something else.
This particular patient, for example, you have already considered that this is Candida albicans.
Yes.
So you can go with
I don't have a problem with that. The only problem I have is that the comment I would have is that in National Guard Jeddah, for example, 40 to 50% of their Candida albicans is fluconazole resistant. So this is another factor that you have to throw. You need to know what exists in your society. Severe ill patients coming to the ICU, we throw an antifungal, especially ER if he has a mild disease. On norepinephrine, yes, we throw antifungal on him. Especially if you are dealing with small bowel, specifically the small bowel, because the disease in the small bowel is associated with a worse outcome and a higher incidence of fungal infection. There is one slide I missed. طيب كم باقي لي؟ 5 دقائق ممتاز. نعدي على one case because we have to visit ICU. 87 years old, morbidly obese female with osteoarthritis, pulmonary hypertension, home oxygen, congestive cardiac failure, typical patient, transferred from a private hospital, again after 1 month stay, cause significant for VAB and bloodstream infections. You see this every day, right? On arrival, mechanical ventilation, 60% FiO2, temperature 38.9, blood pressure 90/50, heart rate 110, on norepinephrine infusion. She is on vancomycin and piperacillin tazobactam for the last 5 days. 5 days old internal jugular access that looked okay. Site looked fine. Chest X-ray, pneumonia. Sputum, gram-negative bacilli. Diagnosis, septic shock. What do you do? If you diagnose septic shock, what do you do? You call sepsis team, if you have a sepsis team. And if you don't have a sepsis team, then you have to at least introduce in your hospital the guidelines of how to manage septic shock. The survival sepsis campaign guidelines for managing septic shock. Because septic shock management is not antibiotic. Septic shock management is so many others plus antibiotic. You have to initiate early goal-directed therapy, and you have to know what is early goal-directed therapy, because even if you are not really doing it, you need to have some knowledge to educate the juniors on what to do with those patients. You have to do an aggressive resuscitation, aggressive but wise resuscitation, so that you will not end up ballooning the patients and causing more harm. You're going to use inotropes once the patient goes to the ICU, and you prefer norepinephrine. No more dopamine. It's just norepinephrine or epinephrine, the most recent guidelines. And you may end up using stress dose steroids if the patient does not respond to any of this. This is the early goal-directed therapy schemes. Every hospital nowadays should have this. In National Guard Riyadh, we have introduced something called Sepsis Team. And Sepsis Team is a parallel team to the critical response team, which basically whenever there is a sepsis identified in the floor, surgery, that team goes, do the assessment, do the necessary lab, and they start therapy. Antibiotic should be given within the first 1 hour. Every hour you lose, you basically increase your mortality. Cut point is 4 hours. After 4 hours, you basically lost the game. 1 hour, the golden hour. Everybody for ICU literature nowadays talks about the golden hour. So what antibiotic would you choose? Continue the same antibiotic while obtaining more cultures and changing lines. Start linezolid plus meropenem. Continue vancomycin and start meropenem plus caspofungin. Vancomycin plus colistin. Colistin plus tigecycline plus echinocandins. You choose. Meropenem plus tigecycline plus fluconazole. Meropenem plus colistin. This is a patient coming from a private hospital. She has gram-negative bacilli. She's been exposed to many antibiotic courses, including, I'm almost sure that one of those were thrown at one time.
Okay, so colistin has to be in the red.
Okay? Colistin plus tigecycline plus echinocandins. So you will use colistin alone with vancomycin. So vancomycin plus colistin. Okay, the blood culture showed Acinetobacter baumannii, and sputum was also showing the same organism. And this is the pattern. We see this every day nowadays. We see even worse than that. So this is resistance to pretty much everything except a little bit intermediate to aminoglycosides, tobramycin, and resistant or sensitive to colistin. Minocycline I have, which is telling you the same story. Type. What would you treat with? As we said, you've introduced colistin. Would you give colistin alone? Well, would you add meropenem on top since you know that organism? Would you add tigecycline? Would you think meropenem plus tigecycline? Would you colistin plus colistin nebs? Your colistin plus rifampin? Ampicillin sulbactam plus imipenem? Ampicillin sulbactam plus colistin? 1 minute, خلاص. طيب, I'll just finish this slide. I will finish this case, huh? This case. This case will take a long time because I'm going to be talking about colistin. So let me just. Very important slides. Remember, colistin is a narrow spectrum or is a wide spectrum drug? It's a narrow spectrum drug. It misses so many organisms that are important. It misses Serratia, Moraxella, Proteus, Providentia, Morganella morgagnis. So i.e., if you have somebody on colistin alone and he has a breakthrough infection, breakthrough fever, remember these organisms because you have to cover them. And a lot of times, these organisms will only be amenable to carbapenems. The other important thing I want you to remember is colistin is not a good drug alone. It actually falls inferior to so many other medications if the organism is sensitive to those ones. The third important thing is that colistin dosing is a major area of confusion. And every hospital, based on the colistin base, have to develop an algorithm of what is the appropriate dose per condition. This is very vital. Otherwise, you will end up under-treating your patient, and there is strong evidence to say higher colistin basically means better outcome. Colistin combination with others does not add any further advantage. Colistin plus NIBs, in old literatures, we were saying yes, colistin plus NIBs, IV plus NIBs. Two recent literature suggested that is not enough. Is not beneficial. If you add the IV colistin to the IV plus NIBs, colistin plus tigecycline, mixing results. Thank you very much. you.